Welcome to the JOMA Preventative Health Podcast, hosted by the Jewish Orthodox Women's Medical Association. We provide you with up-to-date information on health topics geared towards the Orthodox Jewish community. This podcast content is provided for informational purposes only and is not intended as medical advice or as a substitute for the medical advice of a physician.
Welcome to the Jewish Orthodox Women's Medical Association, or JOMA podcast. I'm your host, Elisa Minkin. I am a general pediatrician and proud JOMA member. And tonight I'm really honored and really excited to be interviewing Dr. Lisa Shulman. If there are topics you want to hear, you want to be interviewed, you know someone you want to hear being interviewed, you have comments about the interviews I've done, please reach out to us at health, HEALTH, at joma.org. We want to hear from you. This is a topic that I'm very passionate about. If you look at my past podcasts, you will see that I have done topics related to autism numerous times, and I intend to do more. This happens to be Autism Awareness Month, so it is very appropriate that I do another episode related to autism. This is about the early detection and treatment of autism. I will say that I meant to talk about, but did not get around to talking about new ways of diagnosing autism through videos and through apps. I'm not sure what's commercially available at this moment in time, but I'm going to link this podcast, in addition to some of my other talks about autism, also to a talk with this professor from Duke on the American Psychiatry Association podcast. So Dr. Shulman is a professor of pediatrics at the Albert Einstein College of Medicine at the Children's Hospital at Montefiore. She's a developmental pediatrician with over 30 years at the institution. She is the Director of Autism Services and interim director of the Rose F. Kennedy Children's Evaluation and Rehabilitation Center at Montefiore. She also directs the Leadership, Education, and Neurodevelopmental and Related Disabilities grant through Maternal and Child Health Bureau. She currently serves on the Autism Subcommittee of the National AAP Council on Children with Disabilities, serving on the Education, Learn the Signs, Act Early, and Payer Advocacy committees. From 2016 to 2019, she served as the Centers for Disease Control Act Early Ambassador to New York State. She's a graduate of Brown University and University of Pennsylvania School of Medicine. She is board certified in pediatrics and developmental and behavioral pediatrics. Her clinical and research interests include early identification of autism, overcoming healthcare disparities in autism diagnosis, and follow-up of children with an early diagnosis of autism. Welcome, Dr. Shulman. Thank you so much for joining me tonight.
My pleasure. It's one of my favorite topics to talk and think about.
I know. I heard you on a different JOMA webinar, and I said, I have to interview you. I don't remember what exactly it was that you said, but I saw that you got it. And so I'm really excited to be able to interview you. And I just found out that this is Autism Awareness Month, the month of April. So it turned out to be perfect timing.
Yeah. On that note, I actually want to call upon other language to describe our purpose for this month, which really should be all year. And Judaism has been a source of good information on this, by the way, because February is Jewish Disability Awareness, Acceptance, and Inclusion Month. And so April, why should we just talk about awareness of autism? So if you think about it, awareness is like, oh, autism exists. Acceptance is like a mental piece. I am mentally accepting individuals with autism. What's the action item? Inclusion.
Oh, yes.
So I love to refer to this month as April is Autism Awareness, Acceptance, and Inclusion Month.
I love that. I am so glad you said that. That is fantastic. Yeah, I heard people were complaining about, just talking about awareness without talking about those next steps. It's so important. And we have so much to talk about. And I will say that you are one of many people that I've discussed autism with. So I'm going to link, I think, in the show notes to at least a few of those. And I'm planning on doing more. And I have, by the way, interviewed autistic people as well. And we're using the word autism first here intentionally. And that I'm not going to get into that right now. It's in my other podcast episodes. I think I'm also going to link it to an episode, not one of my podcasts, from the American Psychiatry Association with Geraldine Dawson from Duke about early identification of autism, because it was a new talk that came out, and I think it's very relevant to what we're talking about. So let's get right into it. Your area of specialty and interest is early detection of autism. So I'm going to let you just get started on early detection of autism. Go.
Okay. In the old days, well, let's put it this way. There are some things that when you see them in a young child spark concerns.
Mm-hmm.
And screening instruments are fantastic. They are a way they accomplish two things. They ask parents questions. Is your child doing this or that? And they kind of gauge risk based on the answers to those questions. But they also play a role in alerting parents, anticipatory guidance of what's expected at this age. And so, for example, it's very common when a parent is filling out a screening form that I'll see what I call the sign where the parents aren't sure. Two parents are there. They're not sure if the child can point to their body parts or can go and get an object in another room. And I'll watch them look at each other when I pose that question. And that tells me they didn't know that the child was expected to do this at that age. So I have a very favorite study that was done in the 90s when everybody had one of those giant camcorders. And if you had a baby in the 90s, you can be sure that there exists a videotape of that baby's first birthday. Mm-hmm. So a researcher asked on the then new World Wide Web, if you have a child who was later diagnosed with autism and you have a videotape of their first birthday party, would you share it with me? And she also got videotapes of children who were not later diagnosed with autism. And she had people who were blind, did not know whether the videotapes belonged to children later diagnosed with autism or not, and who looked at these sets of videos and picked out qualities, behaviors that they saw and that were analyzed and found to distinguish between these two groups. So what were the earliest signs of autism evident at the 12-month birthday? They were decreased eye contact, lack of response to name, not pointing to indicate a want, and not pointing to show a parent or someone else something interesting, like a dog across the street or a kite up in the sky. People also add to that not naturally imitating. And then another quality that I'll put on this list in general is you should have 16 gestures by 16 months of age. So before a child necessarily says any words, you should be seeing the waving bye-bye at 9 months, clapping, the pointing to request and show by 12 months, the wheels on the bus, the head, shoulders, knees, and toes, the raise your arms in the air to be picked up, the all done, the looking. And so those are communicative efforts that definitely rear their head very early on. And when they're not there, that is meaningful. I want to get back to the not paying attention when called. So there was a famous video of the grandfather of pediatrics, T. Berry Brazelton, that I used to use in like my very first lectures as a new professor, showing how a brand new baby, like hours old, lying on the warmer. Dr. Brazelton would go on one side of the baby and say to the baby in his very soothing voice, look at me if you can hear me, baby, look at me. And the baby would just like turn and look at him, this newborn. And then just to show that it wasn't a coincidence, go to the other side and do the exact same thing. And the baby would look. Babies literally come out of the womb listening and drawn to language and human faces. But so, and it's due to that interest that, you know, we describe babies as little parrots. You know, anything that they see, they do. Anything they hear, they try to say. But there's a natural curiosity about the face, a natural attentiveness to language. And so if you don't see that early on, then the baby's kind of development of language is often going to lag and be unusual. So that idea of responding to language, looking at mommy or daddy when they talk to the child. And often we gauge that by responding when called by name.
That is an excellent explanation. And I'm thinking, though, I'm a pediatrician at 18 months, but you're talking about signs even earlier than that. Yeah. What do you do as a parent if you're seeing that before that 18-month screen?
I mean, that's kind of the definition between surveillance and screening. The idea that I know pediatricians don't have enough time in their sessions to talk about everything and screen for everything that's supposed to be screened. But developmentally, kind of putting that front and center solidly on, this is what we talk about in pediatric visits. And, you know, how do you think the baby's interacting? How are they doing with their milestones? Like we know, the first year, until the baby walks, everybody is focused on the skills leading to walk, rolling, sitting, pulling to stand, standing, and then walking. But there are signs that are concerning earlier. And so for like high-risk babies who are the siblings, younger siblings of children diagnosed with autism, babies who have biologic risk factors, like they were born very prematurely, they had infection at birth. And those are often kind of things that flag, let's be more attentive to this. And the other thing I encourage pediatricians like yourself and others to do is the screening instruments are great, but, you know, set up your office so that there's some appealing toy high up. How does the child indicate they want it? You know, will they point at it? Will they try and climb it on, get it on their own without attempting to communicate that they want it? Call the child's name yourself. And if you can't get their attention, I always ask the parent, how do you get his attention? And the parent may say, I can't, or I have to go get him. Or they may have kind of adapted in a particular way, stomp their foot and go, Henry, you know, something that is unusual to get the child's attention that you can note. In the pediatrician's office at 15 months, a toddler should have some symbolic appreciation of a toy. A car is no longer, toy truck, no longer something to bang, to put in your mouth, to dump. It is something to push and go vroom. The baby doll is a baby. And so those are precursors. They're the symbolism that turns into language. And so by seeing those, that's encouraging for development. But I definitely would say calling the name, seeking an opportunity for pointing, asking about the child's gestures in general. Do they have 16 gestures by 16 months? Trying to get them to imitate with a toy doctor's kit or feeding a baby doll or other actions. Another kind of red flag early on is walking on the tiptoes. So this ended up being the very first thing I ever did research on. And the story behind it in the 90s was when I was hired to be a developmental pediatrician at my center. I was informed right from the start, we're hiring you, but we don't have room for an office for you. So you're going to run our mobile team and you're going to go be a consultant in different pediatric clinics. So I went to a pediatric clinic and met with the head of the clinic, who was an extremely experienced pediatrician and who I had a lot of respect for. And he said, so like, who should we refer to you? And I looked out in the waiting area and there was a little boy, toddler, high on his tiptoes. And I said, well, like him. And, this experienced pediatrician said, well, I'd refer him to the orthopedist, but why would I refer him to you? And I said, because walking high on the tiptoes is associated with autism. And he said to me, is that in the literature? And it was not. And so that became one of the first things that my name is associated with. And,
Wow.
And to this day, it is an early sign. It's totally recognized that it's a prevalence issue. So about 2 to 5% of new walkers, young toddlers, walk on their tiptoes. But 20% of children diagnosed with autism walk on their tiptoes. And for some, it's an enduring pattern that requires treatment. But it is basically, if a child, you're watching your pediatrician, or you're watching your child begin to walk and they're walking on their tiptoes, as pediatricians or as doctors, we teach the onus is on you to make sure this child walking on their tiptoes does not have autism. Okay, there certainly are children who do not have autism, but make sure you have checked this child.
Right. I mean, I think this is true for a lot of things that we could see, like hand flapping or rocking or head banging. These are all behaviors we see in typical children. And I find that parents are more often anxious if their child has autism with no other signs with these things. I don't want people listening, particularly parents, to get anxious, because these are all, including walking on toes, are really common seen in typical children.
Again, it's a matter of prevalence.
Right. It has to be put in context. That's the thing.
Yep.
So, you're talking about really early signs, but I find as a pediatrician, I struggle to get a child diagnosed even after 18 months. What would you say is the average age now that a child is diagnosed?
Well, officially, it's around 4.
That is late.
And it really is probably something that has 2 peaks that we need to take into account. So the more severe the autism, the more likely it is to be diagnosed earlier. Milder versions, or what used to be called Asperger's syndrome, that is a child who has typical learning and intellectual development, speaks in full sentences, often is quite verbal, and that child is more likely to not be diagnosed until they enter a school program at pre-K or kindergarten, when the first concerns may arise. So one of the obstacles to an early diagnosis is definitely at what age does concern arise? And so the child who is not speaking at all at 2.5 or 3, somebody's going to start to say, well, let's check his hearing or her hearing. Comes up 4 to 1 more in boys than girls. But for children with milder symptoms, it is definitely natural that this is a diagnosis that often requires being seen in a context of school, a group. Other things, though, can get in the way of an early diagnosis. So one of the whole reasons the Learn the Signs, Act Early campaign was developed was to make sure that the phrase learn the signs, act early. As a fellow pediatrician, it's an illusion that bothers me, but the idea was that many a parent will say, I raised my concern to the pediatrician, and the pediatrician suggested watch and wait. And so the whole intent of this campaign was directed toward pediatricians, but also daycare providers, the WIC program. Basically, it kind of attempted to mobilize anyone who has contact with young children. If there's some concern in these realms, don't watch and wait, refer and monitor, and or get services if the child is eligible. So the idea that you don't have to be sure that the child has autism to go down that path. One of the things that early intervention and the Committee on Preschool Special Education, or the school district, work on a model of eligibility for services based on percentage delay, or having a statistically significant delay. And so a child with early signs of autism, but who has not yet gotten a diagnosis, can qualify for speech and language, qualify for a special educator who's working on play skills. And New York City is unique in the United States in that in the 5 boroughs, the early intervention program does take responsibility in certain cases for making an autism diagnosis through a psychological evaluation in the early intervention program.
So I'm from Long Island, so that doesn't include that area.
Long Island does not.
So wait, I want to clarify what you mean by take responsibility, because on Long Island, you can get a diagnosis through early intervention, but it doesn't happen unless it's requested by somebody.
Okay. So yeah, so in the 5 boroughs, from the very start of early intervention, this was an era in which it was very common that standardized, one of the greatest contributions of early intervention and the early intervention program was implementation of the use of standardized instruments to make all sorts of diagnoses. And early intervention, just like the school district, they're not diagnostic systems by design. Mm-hmm. They are eligibility assessments. So an early intervention evaluation is determined if the child has a 33% delay in one area or 25% delay or more in 2 areas, and then the child is eligible to receive therapeutic services to address those delays.
I want to say something before I forget, that as a pediatrician, we see a lot of speech delay. And because of that formula, if you send before age 2, they have just an expressive speech delay, which is really more common than autism, where they understand everything, they're socially related, but they're not speaking adequately, they will not get services before age 2. So we have a lot of kids getting referred, acting early, the doctor's acting early, filling out that form, getting them over to early intervention, and they're getting rejected.
Right. And that is because they average receptive and expressive language. But the child whose attention you cannot get, who cannot point to any body parts at 18 months, who can't go get their shoes on, command, or put this in the garbage without a gesture, that child will qualify by 2. And I will say that there are other resources. So let's say it's common at the center that I'm in charge of, that we will see a child in front of us who very clearly has significant delays, let's say in speech and language, and did not qualify for early intervention. And we'll look at the evaluations, and it'll turn out the child's 31% delayed in speech. And again, they're not 33% delayed, but the American Speech and Hearing Association, the American Academy of Pediatrics, the American Psychological Association, and common sense will tell you that child, of course, should receive speech and language therapy, and in fact, can benefit the most from speech and language therapy. And so there are other systems available to treat that child other than early intervention, namely through insurance, through medical or hospital-based system. So the child would benefit from speech and language, but as we kind of interpret this for parents sometimes, because it is so confusing, early intervention is set up to serve children who have a very significant delay. And so thankfully your child doesn't reach that level, but the child would benefit from therapies.
But just in terms of advocacy, I always tell parents, you need to tell about your child on their worst day. You don't lie, you tell the truth. But sometimes you feel like, I want to tell how smart my child is. No, you do not. You want to think about your child on their worst day. Because it's true, because to have a child score 31%, maybe you've buffed them up a little bit, they've just missed eligibility, but they need it.
True. But there is another way into early intervention, and that is with certain diagnoses. So there is automatic eligibility for early intervention on the basis of, for example, being premature and weighing less than 1,000 grams, having a grade 4 intraventricular hemorrhage, having various genetic syndromes that are known to be associated with developmental delays or chromosomal abnormalities. There are scenarios like infantile spasms that are a child's automatically eligible for early intervention, having cerebral palsy, having hearing loss. So the medical documentation can make all the difference between a child qualifying for early intervention, which again, that generally goes through this eligibility based on percentage delay, but the medical documentation of these diagnosed biological or psychosocial risk factors for developmental delay can also make a difference. And we'll use that terminology as doctors to basically say this child is automatically eligible for early intervention. Because if you think about it, a child discharged from the NICU who literally should not have been born yet is not going to meet any equation of delay. But if that baby was a micro preemie, had very significant complications in the NICU, that child will be given therapy right from the start on the basis of meeting these automatic eligibility. And autism can be one of those if standardized instruments were utilized. But getting back to what you said, New York City does not require that you request an autism evaluation. If clinicians or a parent sees something or concerns are voiced about the child's social functioning, whether the term autism is used or not, then the early intervention program in New York City will carry out that evaluation. And in fact, in order to get ABA or autism specific services in New York, you cannot come with an outside evaluation. They have to be the one to do it. So it is different than in New York City than the rest of the state, which follows more like what you're describing, Long Island.
Right, but with enough awareness, a parent outside of New York City, but in New York State, I don't know about the other states, can request that evaluation. And I want you to talk just a little bit about what measures we use to decide whether a child is on the autism spectrum.
So we were talking before about screening instruments. So officially, it is recommended that children be screened at 18 and 24 months with something akin to the modified checklist for autism in toddlers, or the MCHAT revised, in pediatric visits. That is not a diagnostic instrument, but that flags a child as needing additional assessment, or if at any point the parent or the pediatrician, based on their observation that the child doesn't respond to name, isn't imitating, and the other things we spoke about, if there are concerns. So then one of the biggest difficulties with diagnosis is access. So there are insufficient diagnostic resources. Again, utilizing early intervention to the utmost is an opportunity. The school district, so after the child turns 3, it is much, much, much more difficult to gain access to that. That is definitely not a diagnostic system. And so you have a situation where different communities have different diagnostic resources. So there are medical specialists who can make diagnoses, developmental behavioral pediatricians, psychiatrists and neurologists can make diagnoses, but typically do not, unless they are highly specialized in this area, use the standardized instruments that are required for the diagnosis. And by that, I mean either the Autism Diagnostic Observations Schedule, which is a play-based choreographed assessment, the ADIR, which is an intensive parent interview, or a model we have always used and is more popular these days since the pandemic, which is the Childhood Autism Rating Scale, or the CARS-2. Those are standardized instruments. They operationalize the DSM-5 criteria. The CARS gives a level of severity. So they go hand in hand with, does the child meet the DSM-5 autism spectrum disorder criteria, which then kind of lays out the level of support required. Is it associated with cognitive delays? Is it associated with language delays? Is it associated with emotional behavioral diagnoses or other medical problems? And is the etiology known? And the CARS is an instrument that we utilize to operationalize those criteria, characterize a level of severity. Is it mild to moderate? Is it severe, or in the not in the autistic spectrum? And then becomes an instrument to continue to use to monitor response to intervention or how the child does over time. So you have to find a place that uses a standardized assessment. Psychologists are also major diagnosticians in early intervention, in academic-based programs, in private programs that are diagnostic. So I would say in general, psychologists and developmental behavioral pediatricians and specialty trained pediatricians are now being utilized and mobilized as a workforce for this through special educational opportunities like ECHO training, mini fellowships for children who have obvious signs of autism. There's always going to be children who are really tough calls. Is a shy temperament, social anxiety? Is this kind of a quirkiness? Does this cross a line into autism spectrum disorder, or is this social weaknesses as part of ADHD or something else? And for those assessments, I would say in general, an ADOS is very useful in operationalizing that. Another instrument.
Stop you just a minute. The ADOS is commonly used, at least in Long Island, for an early intervention, and it's really hard to access outside of early intervention. I find it really hard to get patients in a timely fashion to anyone who does that. Right? Like a developmental pediatrician,
that's part of the
1 year wait list, 1 year.
Right. That is part of the reason why we at my program are big advocates of use of the CARS for obvious cases. And it isn't a strategy throughout the country for increasing access. So for the type of child who is showing the hand flapping, is very clearly showing signs of autism at a certain age, the CARS allows a diagnosis the day we meet the child, especially if the parent is ready to hear that diagnosis.
Right. And a general pediatrician could do it. It's a very simple questionnaire. No?
It's based on observation. So not asking parents questions other than to supplement your answers, but it is based on 15 features that the examiner observes. So somebody trained in it, definitely.
Oh, it must be a different version than I've seen in the past.
It was always intended for completion based on observation.
Oh, I thought it was like a parent questionnaire.
No.
But you're kind of implying it's not as sensitive and specific as the ADOS or the ADR.
No, it is very good for diagnosing in very experienced hands. It's excellent. And what I would say is that for a child who is, if a clinician is trained in it and a child has many significant signs of autism, you can't get their attention. They don't have joint attention. They have unusual body movements. They do not use language for wants. You know, this is the type of child who I'll get a call from the registration person at the front of my center, who obviously, even though not trained, is an expert in autism. And she'll call me and she say, how much longer until you're going to take your patient with autism? He's having a very hard time waiing. And of course,
already made the diagnosis.
He's never been diagnosed with autism, but she knows autism.
Should trademark her.
This is a good, I mean, for the clinicians on the call, the CARS is a very useful instrument. Like, one of the ways we increase access at a center like mine is in the Bronx. It is not we don't have an autism center in that if parents are looking for autism diagnosis, that's how you get an autism diagnosis. What we say is we bring our autism expertise to the front door. Every child who walks in the clinic is evaluated for autism at every visit that they have through instruments like this. Because just waiting for somebody to voice the concern, I'm afraid my child has autism, can you please evaluate them for autism, is a bar that many parents are not at. So there are two big things that impact on access to diagnosis or present obstacles to diagnosis. The first group of things are parent-driven things. The parent is not, like these days, autism is a household word, but there still are communities, new immigrants, and the younger generation, sometimes we'll see teenage moms that somehow do not know what autism is. It brings me back to, again, the 90s when we were dealing with a population where autism was not a household word. And we would be giving a diagnosis of autism to a family who had literally never heard the word. And we had this pictorial representation of the features of autism, child walking around as deaf, child not speaking, and the parents would circle the features they saw and go home with it. And often a grandmother would call, so they say he's artistic. It was just an unfamiliar term.
Right.
These days, almost everybody has heard the term, but the idea that it applies to a particular child is very variable. And I would say most children under 2 years of age do not have the classic hand flapping, unusual movements between the eyes. So that if you're looking for certain, repeating large scenes from favorite movies, they don't have that much language. If you're waiting for the child to demonstrate those signs, what we usually say, you'll miss every toddler with autism. And so this kind of idea of looking for these more subtle signs in every child who has language delay or doesn't respond when called is a way to raise this as a concern with a family. And then hand in hand with that, because the worst thing in the world is to raise a concern and then not address it. And so, so this set of access issues related to parent issues may be lack of knowledge. It may be lack of, a state of denial or not readiness. Parents of a young child, and often pediatricians that I work with, when we see a 21-month-old who is referred for language delays or concern of hearing problems. And because we know the signs of autism and can recognize them in very young children, will raise that what we're seeing seems to be social weaknesses underlying these language delays. And a parent may say, or one parent may say, well, I didn't talk till I was 2.5. Let's give him some extra time. And unfortunately, we do feel like the clock is running, because there are certain profiles of children who, and this is why we're, learn the signs, act early, who really benefit from the initiation of intervention very, very early.
Yeah, let's talk a little bit more about why it matters.
Okay. The other thing I just want to say to finish up that answer was there are also systemic reasons that impact access to care. And that is that a lot of the diagnostic services are hard to access, may not accept insurances. You need to know somebody to get off that year-long waiting list. And throughout the country, the vast, vast majority of early intervention programs, even if you ask for it, will not do an autism evaluation. That is not their bailiwick. They are eligibility, not diagnostic. So there just aren't enough diagnostic resources. And so that's a large part. Often when they ask parents whose children were not diagnosed until much later, the parent will describe, I've had concerns for quite some time. I brought it to someone else's attention and they said to watch and wait, or, he's progressing, he was a preemie, whatever the concerns were. And so parent reasons and systemic reasons can get in the way of the delay and get in the way of the diagnosis and delay the diagnosis. Okay, I'm sorry, you were
Actually,
changing.
now I'm stuck on diagnostic barriers though, because if you have to be certified in one of these tools and you didn't get it through early intervention, how else could it be diagnosed?
Yeah, I mean, there are developmental centers and developmental pediatric practices and practices that include psychologists. You know, what we usually urge in kind of national presentations are know your local resources that are diagnostic. Again, so early intervention is an eligibility system. When we talk about diagnostics, we say who makes diagnoses? Doctors, and in this case, psychologists. And so most hospital-based programs have a diagnostic model for diagnosing autism, whether it's under developmental and behavioral pediatrics, neurology, psychiatry, whether it is through psychologists who are part of the program. So throughout New York, there are these systems. So I'm at Montefiore at the Rose F. Kennedy Center, but Columbia, Cornell, and then there are the private places like Child Mind, but Long Island Jewish has a diagnostic program. So again, Stony Brook has a very big program. So again, these hospital-based programs.
And I'm going to point out that some of them don't take insurance and some of them only take private insurance.
Right.
And so there's a tremendous inequity issue here.
That may be, you know, I would say at the programs that I listed in New York City, those hospital systems take Medicaid.
Okay.
And I would say the majority of the patients at my center have Medicaid. So it shouldn't be this difficult. Knowing your local resources and giving parents options. You know, as a physician who needs and wants to help families and facilitate a diagnosis, you know, it's a system built in with inequities.
Right. And a general pediatrician or physician couldn't diagnose autism just by following the criteria on DSM?
So that's what I'm kind of referring to with the use of the CARS, the ECHO model, the mini fellowships, is that there is a movement afoot to empower general pediatricians with this interest and some amount of training to be able to do this for clear-cut cases. And then we quickly get into, to be honest, at this point, especially pandemic related, even once you get a diagnosis, it's not necessarily easy to get the
right. Now we're ready to talk about the next set of barriers.
Yeah, but this idea that empowering diagnosticians like pediatricians, nurse practitioners with this interest who get some specialty training in the instruments is a path toward easing diagnosis. But I'll counter that with what we're about to talk about now. There is nothing worse than giving a diagnosis and then the child can't access treatments.
Oh, we were going to talk about why it matters so much.
Why it matters. Okay, so I'm going to describe this child who we cannot get this child's attention. Okay, so I have patients that I see like this every day. I could call their name 1,000 times. I could strip in my office and this will not get their attention. So we were saying, how do little children learn? The expression, children learn what they live. They learn what they live because they're nosy. Little children come out of the womb nosy. They're nosy about their older brothers and sisters, the other children they see, everything their parent does. But children with autism are generally not socially motivated and not nosy. And so this idea that children learn through imitation what they're exposed to does not apply for children with significant autism. Again, more likely to be picked up young. And so for this group, there's a need to kind of figure out how do we get this child's attention? And there are two basic approaches and two basic models for that. One of them is, and this is kind of relationship-based models. Floor time is another word or another one of those types. It's going to say, well, this child likes to spin things. I'm going to get involved with that and in fact show them this toy and what I can do with it. I'm going to join them. in what they're interested in and smile at them and get their attention and show them how fun it is to do it reciprocally with someone else. And through that relationship that I'm building based on that child's motivation, we're going to work on imitation and shared eye contact and shared affect. And that is an approach. There are kids for whom we literally cannot get their attention, or it's just not reliable. And so the behavioral model, applied behavioral analysis, an example of that, or naturalistic behavioral interventions. The idea is I'm going to reinforce, I'm going to kind of demand your attention and reinforce that. These are Skinner's behavioral principles of if you reinforce a desired behavior, it will occur more commonly. Going to reinforce with a preferred toy or an M&M, respond when I call your name. Once we've ascertained the hearing is normal, this will prime a child to be more likely to respond. I'm going to teach you skill by skill and reinforce it, to pay attention to what I do, to learn to imitate. And the thing about behavioral interventions is that they can be focused on teaching individual skills. And you can utilize some of those skills, like responding to language, learning to imitate, taking turns, to help a child become a more natural imitator and learner in more casual situations, like preschool, like shul groups. So the child who's off doing their own thing and isn't nosy and isn't paying attention, the behavioral techniques can be used to, that doesn't come naturally to this child, but we're going to reinforce it, that set of behaviors, and help the child become nosier and more interested in their surroundings. And then the other approach is to basically say, we're going to use these play-based activities to just work on this child's social motivation if there's some nascent social motivation. So children with different profiles often are recommended to, or should be having a program that's tailored to their particular needs. Kids who are more of the Asperger's profile. The importance of early intervention for this group is that if the child is not nosy and is not learning casually, they're going to learn very idiosyncratically. And they're just going to get further and further from the typical trajectory of developmental gains, because they're learning in their own idiosyncratic way. And so there are a group who, when you teach them this skill by skill, they again become more casual learners. They learn more from their environment. They get closer to the curve and are real responders. So is that every child? Absolutely not. But is that a subset of children? Yes. And there are many in between who can learn discrete skills that are useful functionally and in life.
You know, you're talking about two different approaches, and I just want to take a minute to discuss some of the controversy over ABA, if that's okay with you, and bring in the
Sure.
neurodiversity movement for a moment.
Yes, go for
I
it.
interviewed, by the way, Dr. Barry Prezant, who has a different model that is not so available in the New York area, called the CERTS model, social communication. I can't remember the rest of it. But it's more similar to floor time and more responsive to the child and interactive than classical ABA would be.
Okay, can I mention another model?
Sure.
Okay, so we were just talking about models for young children.
Mm-hmm.
Now I want to talk about the 3-year-old who just started nursery school and doesn't talk to the other kids. Parents have thought he is brilliant. He has the best vocabulary. He's a star. They go to the first parent-teacher conference and the teacher says, you know, he talks to me a lot, but he doesn't interact with the other kids. I realized recently he doesn't know the other children's names. He refers to them as boy and girl. He is an expert in the New York City subway system. And if I need to get from point A to point B, he's totally my guy. But when the class is talking about this book we just read or the weather today, he'll try to bring that conversation to his interests, and he doesn't have a two-way conversation. Now we're getting into a type of child who ABA and floor time are not the interventions for this child. This is a child who would benefit from being taught and kind of help to understand through a model. And I'll give as an example, Michelle Garcia Winner's social thinking model, that, I want to play with this other child, but he's walking away when I start to talk about the subways. What can I do? What signs are there in his face or in his body language that are telling me something? And there's a skill-based approach that's using the child's strengths, namely their smarts and social motivation, to provide a structure and strategies to help the child utilize their social abilities and grow with them. And so there are, again, ABA is not at all for everybody and should not be. So the days of, again, the early days of early intervention that I think led to New York City putting up this barrier that outside doctors couldn't refer in with an autism diagnosis. Early intervention providers had to diagnose it, was that doctors would take out a prescription pen and say, diagnosis autism, 40 hours of ABA. And so again, ABA is definitely not for everybody. Okay, let's segue to talking about why ABA is a hot topic these days. Okay, so I want to go back a little bit to basically say, we spoke before about the ADOS as a diagnostic instrument, and that it is more sensitive in certain ways. And you know who it's sensitive for? Children who have a lot of language, have normal cognition, and who were kind of, again, that group that were saying, are they shy? Is it their temperament? Are they anxious? Are they schizophrenic? We're sitting there trying to sort this out. And that's a group who has tremendous strengths. And there is more subtlety to figuring out, do social weaknesses underlie this? And the ADOS as a standardized instrument basically defined what is mild social impairment. Through this standardized instrument, it literally defined the mild end of the curve. And it's kind of like, the Big Bang Theory, for those who watch it, popularized the idea, even though it's never said, that Sheldon has autism. He crosses the line. He has to always sit in the right place. He can't drive a car. He has his functional impairments. His other nerdy friends, they don't have autism. Okay, so an ADOS would be able to make that distinction. And so with the definition of mild autism that became known as Asperger's under DSM-4 and now isn't, there has been the growth of this idea that there is a mild end of the spectrum. In the past, in the 80s, 90s, under DSM-4, this did not exist. And the percentage of individuals with autism who had co-occurring intellectual disability and significant language impairment was like 70%. Now that's gone down to less than half. And the milder cases are much more common. And the idea that somebody who is bright and verbal and can think introspectively and communicate about their earlier experiences, or who may have always felt different, didn't fit in. And I understand there's a whole trend that I hear about now of diagnosing yourself on TikTok if you have certain qualities. I'm not saying these individuals don't have an autism diagnosis or don't warrant and shouldn't have gotten one earlier. But again, the mild end of the diagnosis got defined. It exists. There is more awareness of autism, and there are people who literally are saying, I should have had a diagnosis when I was younger. I'm 30 years old. I'm 40 years old. Or I'm 21 years old and I did not get that diagnosis. And so people, though, who did get diagnosed in the 70s, the 80s, or 90s with autism and had and developed language and the ability to communicate, have recollections of receiving ABA that was given in an era in which it was not naturalistic. It did not look like play. It looked almost like punishment, and sometimes there were punishments. Instead of reinforcing and positive reinforcement of behaviors, there may have been, because there was an era in which this was, and this is not the case now, punishments may have been given if you didn't respond to name or didn't imitate. And the experience itself may have felt extremely negative, hours of being almost, in a high chair, needing to do what this person was doing in front of you that was not fun. And so you have people who have the voice to speak of, who identify as having autism and who recall these early or maybe ongoing really negative experiences with ABA, giving voice to that. Now, ABA has changed. The main children who should be receiving ABA do not have those capabilities. And so it's a voice that's, I would describe, quite negative about ABA, but there is a population who really needs ABA, and ABA is not what it once was in terms of being naturalistic now, in terms of whenever possible, doing it in a setting that is not highly secluded, that doesn't involve punishment. It should not. I'll always ask parents when a child gets ABA, especially at home, what's your child's reaction when the therapist comes to the door? Are they running away? Are they hiding? Is this something that they look forward to? Does it look like play, or does it look like the child strapped to their high chair? It should not look like the latter.
Right. Not every ABA therapist is a good.
That is true.
It's
And
really
parents,
important as a parent to advocate for your child. There are tons of people, coming out with these degrees who, may not be that good at it.
and as a parent, you should be involved in setting what are the appropriate goals, and not, to be involved in monitoring it, and kind of seeing what it looks like. And also, often parents will, by watching how a therapist speaks to the child, utilize some of the techniques that they see, because they are effective. And so this should be a joint parent-child therapist. And definitely the idea that in EI or in a school that's an ABA school, goals are established, and a parent should have input on the goals. Are these appropriate goals?
And the therapist too, you are allowed to say, I need a new therapist. This one's not working. But that doesn't mean you're going to get someone, because that's a whole other issue of access of, who's out there. And I also want to know from you, how many hours do you think of intensive intervention? I'm using that more generally to say that there are other things besides ABA, like floor time that you mentioned before. It doesn't have to be ABA, but I think it does have to be intensive, correct?
So the little child who's of early intervention age, I would start with 10 hours. And there should also be speech therapy that looks like playing, working on play, occupational therapy or a sensory gym. There should be a set of services. And in many ways, you'll get information about the child. What motivates them? When do they best engage? When do they give you those genuine smiles? And that's telling you that's an activity to do more of. I'm never a fan of like 40 hours of ABA a week. And again, if a child has social motivation and pays attention socially, then if they can imitate and learn from their peers and learn in the setting of what the group does in a preschool, in a daycare, participate in circle time, then you definitely want them to have that experience with support. And that support may be somebody with some behavioral expertise, like ABA trained, or it may be a special educator or a speech therapist, or, a really capable teacher's assistant who really gets how the kid works. But the idea is to facilitate and help them be successful alongside perhaps a social thinking curriculum. One of the terms that we use that I encourage parents to embrace once kids get to preschool age and school age is schools are used to providing an academic curriculum. When it comes to a child with autism, what is needed alongside the academic curriculum is a social curriculum. How is the school meeting my child's need for a social curriculum is the question that I urge parents to ask. So the child who has autism and is academically able to do the work, but may have meltdowns, doesn't have anybody to play with at recess, how is that child's needs being met in that setting? Is there a phys ed teacher outside who organizes a game for the kids, or a counselor who organizes a game for the kids who don't have anybody to play with at recess? Is there a lunch bunch where kids are having organized conversation who may not have somebody to eat with or have a conversation? Are there social thinking groups that occur throughout the day? Is there a methodology for a sensory break for a child who's feeling overwhelmed? Kind of viewing these as therapeutic opportunities as opposed to behavioral problems is very important. And often parents, especially for the child who's verbal and academically capable, often are needing to utilize this vocabulary and model it for the school in order to make sure that things are viewed as they should be through a lens of social weaknesses for the child with autism.
Do you find in New York City that they consider this part of a free, appropriate public education and not just academics?
Oh, absolutely. For the child whose classification on the IEP is autism. In New York City, there are specific autism programs in the public school system called the NEST program and the Horizon and the AIMS program. And that is kind of the strategy for making a case. Is my child best served in an autism specific program, or by parental choice? Do I want the child to be in the mainstream class? Do I want them to be in an integrated co-teaching class? If the school systems don't have this, like we see many children from other places outside of New York City. Again, that terminology of my child has these social needs as part of their diagnosis of autism. How is during the course of the school day is the child's needs for a social curriculum? He's there in school for 7 hours a day. An academic curriculum doesn't cover the basics. Well, how are we working on these things? And that is a way to engage in a conversation to help make the case that the school needs to be involved and view this as their responsibility. So you said early on that parents have to advocate, and they really do.
You really, really do. And not all school districts are created alike, right? It can be very, very hard to advocate, for the social needs, which are hugely important for all kids. I mean, I wish that were incorporated everywhere, social emotional learning, and really not just giving it lip service. But it's not, we're not there yet, unfortunately.
I think there's been progress.
We have to push for it. And I think, each parent pushing for their child, neurotypical or neurodivergent, right, can get us there sooner. We could talk all day. I want to do one more thing before we finish. I mean, I've been loving this. I'm learning just from listening to you myself. I want you to just talk for just a few minutes, if it's okay, about the Asperger type. I keep using that term as if it exists, because we're talking about what you're calling more mildly impaired, although it's not necessarily mild. The higher end of the spectrum, I don't know how else to word this, for not getting a diagnosis, because I deal with this all the time as a pediatrician. There is still stigma. There's still parents who don't want the diagnosis or had it when they were younger and were happy to have dropped it. What happens to those kids if they're not getting the services they need?
Yeah, I mean, I think that last part, at some point, there's an instrument actually that I use in the context of this conversation. It's called the Social Responsiveness Scale by John Constantino, has a preschool version and a school age version. And it's 65 questions, and they're to be completed by a parent or a teacher or someone else who knows the child well. And then there's a total score that either falls, and the idea behind it is there's a wide range of reciprocal social capability. There are social stars, even at 6 months of age, who read the room and know just how to get everybody's attention and get them to do what they want. And then there's the normal or typical range person who is not a social star and relatively social weak, but functions. And then you have a mild range that may be associated of social weaknesses that may be associated with ADHD or temperament or anxiety. And then you have the different levels of autism. And the instrument also then breaks down into different treatment needs, subscales. And so I often see parents, again, because we bring our autism diagnostic capability to the front door, I'm often seeing parents who do not have that on their radar or are not voicing it, or come specifically to say, somebody said he was autistic at school and he isn't. So I wanted to come here so you would show that and document that. And so I'll usually I'll have an opinion myself. I'll ask the parent to complete this form. And sometimes they will describe that the child has social weaknesses. And then we can have a conversation of the things you're identifying. They may have in their head that have had experience with a very severe individual with autism, and they're saying, my child isn't that. But I can say, you know what, you're describing some social weaknesses in your 7-year-old. What if there were things we could do now that would not dictate his life, that would give him more options, not change who he is, but give him more options? And then we would look at the profile and say, he has weaknesses in social know-how. He's socially motivated, but he could benefit from some structure and help in learning how to initiate a conversation with peers, take turns, let somebody else decide what the play theme is going to be, deal with his rigidity or kind of wanting to constantly talk about the planets. And the parent, when presented in that way, may very well say, I understand what you're saying. And I will often say, we don't have to go down the diagnostic path here necessarily. These are, there are resources and groups in many different places, privately, outside the systems at YMCAs and JCCs that provide these sorts of opportunities. And then there's kind of a discussion. It becomes something that you can monitor. And by the time the child's 7 and 8, they have their own opinions about these things. Our biggest intervention is social thinking groups. And often in the course of meeting a child, the child will say, I don't have friends. I want to learn how to have friends. So you have many voices and many ways to kind of think through what works for an individual child and family. And it isn't completely all or nothing. That the idea is interventions can be helpful and increase options. We're not trying to change anyone. There is a wide range of normal. The neurodiversity movement is valuable in characterizing that there is a wide range of the typical human experience. And yes, in honor of Autism Awareness, Acceptance, and Inclusion Month, we want to embrace it all. And when those qualities impact, autistic qualities impact on a child or a young adult or an older adult functioning, and they want to work on certain things to give themselves more options, more ease, there exist evidence-based interventions to do so. Are they easy to get? Are they easy to find? No, we have a long way to go on that. But the definition of mild autism has been amazing in that it views, as it should, the idea that there's a wide range of the normal experience, but all of us are works in progress. Why shouldn't social skills for the individual who wants to work on them?
Right. You're looking at it from a different lens than I was thinking you would, or at least from what I'm thinking. I'm thinking about the teenagers that do not have the information that they are on the autism spectrum and who have a higher rate of anxiety and depression from the already high rate of teenagers nowadays.
Right.
They don't know why they're different. They're struggling.
That is a group that the decision to be made is, if you see things that are concerning you, that this is a question, the conversation, though, still may start with the parent with that instrument I'm talking about. But it is something that can also be broached with the teen. But it can't come out of nowhere. It has to come out of a trusted relationship. So as a pediatrician who's known this child, that may be just the relationship. But I would say often I'm meeting a child for the first time in that scenario, and I will seek to involve the parents and get more information from the parent with a form like this that gives them, again, we started this session talking about how screening instruments provide anticipatory guidance. Did you know that your 18-month-old should be pointing to body parts? So these questions ask for, how does your child do with initiating an interaction with others, with their rigidity in various regards? And by getting some information there, you may be actually giving information, and you are also saying this can lead to helpful interventions, and often starting with the parent. But if the child asks, and I have had 12-year-olds ask, am I autistic? The parent thought the child had the parent was slightly concerned. And then the child told me he did his last 3 book reports on autism.
Yeah.
And you kind of say, what made you decide to do that? So, children with that verbal, bright profile, they know they're different. And it can be very assuring to say, would you like to meet children or, other teens who view their strengths and weaknesses in the same way? There are various programs like technology-oriented, the Transit Museum, that kind of attract and in fact are structured for children, teens with high-functioning autism spectrum disorder, and have kind of embedded in their social skills groups and also social opportunities, recreational opportunities. So again, it would be fantastic if when we diagnose, here are the menu of your choices. They're easily accessible.
Right.
It shouldn't be this hard to make a diagnosis, to gain access to those resources. And I think we're making progress in certain ways. I think the pandemic was a setback, but I think things are moving along. But it's an ongoing need as more and more children are being diagnosed, and adults. So now the numbers are 1 out of 36 in the most recently released numbers from the CDC. One very, very interesting thing that speaks to increased access for marginalized groups is that for the first time, there aren't significant discrepancies between white, Black, Hispanic, Asian children in age of diagnosis.
Is it still 4 out of 5 are male?
Yes. 4 to 5. 4 out of 5 are male. Yes.
Because I was thinking that would change because I think the girls are underdiagnosed.
Yeah, that's a common topic these days, about they're better at camouflaging their symptoms.
Right. And back to camouflaging or masking, that's another advantage to getting the diagnosis. It's extremely stressful to try to fit in with what you perceive as normal. And that's where the neurodiversity movement gives us such a gift of saying what is normal, right? There was a great line from a podcast. I want to give a credit, but I don't remember the name of it, is Why should you try to fit in when you should be standing out? I'm messing this up entirely, but you get the basic idea of it, is that there's a much more positive spin from the neurodiversity movement. And that's why I think we're going to have more and more adults and older kids wanting to have the diagnosis, as opposed to wanting to try to continue to mask just to fit in with what they perceive as normal.
And as we were talking about casually to start off with, that is a very important voice in the autism community. And another important voice that we can't push aside is for children, teens, adults who do not have a voice, who are nonverbal or minimally verbal. Who is their voice addressing their needs among the autism community? And parents have an important voice, guardians, and that fills out the spectrum.
Absolutely. And also the concept of, instead of saying low functioning, high functioning, to say high support needs, low support needs.
Yeah,
because you're going to someone who's nonverbal, they say, just because I don't speak doesn't mean I have nothing to say, right? So we don't even know necessarily what someone's intellectual capacity is if they're nonverbal and they're not able to show us in some way. I know there are tests for nonverbal IQ. I know that, but I think we should suspend judgment, right? And like, I love that you said, I'm gonna let us end, because we could talk all day, but I'll let us end again by reiterating that you said that it shouldn't just be Autism Awareness Month. It should also be acceptance and inclusion of everyone in the entire community of autism and neurotypical, everyone. And we have a ways to go, but we're making progress.
Yes.
And I want to thank you so much for doing this with me.
My pleasure. It was very nice to meet you, Elisa.
You too. Thank you.
Bye-bye.
Thanks for listening to the JOMA Preventative Health Podcast. If you've enjoyed this, please rate and review us on Apple Podcasts and share this with your friends. For more information, check out our Instagram at JOMA_org. Check out our website, www.joma.org, that's JOWMA.org, or email us at health@joma.org.